Are you curious about Gestalt language processing? You are not alone. Join me, Corinne Smoose, and speech therapy PD for our podcast, The Gestalt Get Together. Our episodes try to balance the enthusiasm and excitement about GLP and its associated intervention ideas, as well as a healthy dose of skepticism about how to understand and integrate this paradigm shift into your career and the field at large. We hope that you can get together with us to learn more about Gestalts.
Welcome to Brainstorms, Functional Neuro Rehab for SLPs, presented by SpeechTherapyPD.com. This podcast is designed for the adult medical speech-language pathologist. Most of our audience members work in settings such as acute care hospitals, private practice, outpatient hospital clinics, and inpatient rehabilitation hospitals. Each episode has an accompanying audio course on SpeechTherapyPD.com and is available for 0.1 ASHA CEUs. The content of this course is based on the research and experience of the presenters. The listener is responsible for researching to determine if the information and skills taught are appropriate for their clients, students, or patients. SpeechTherapyPD.com does not necessarily endorse, recommend, or favor the information shared, nor any of the claims, opinions, statements, offers, or services made by the presenter. Hello, and welcome everyone. My name is Renee Garrett, and I'm your SpeechTherapyPD.com podcast host for Brainstorms, Functional Neuro Rehab for SLPs. Before we get started, we have a few items to alert you to. Each episode is 60 minutes and will be offered for 0.1 ASHA CEUs. Here are the financial and non-financial disclosures. Dr. Rene Utianski receives a salary from the Mayo Clinic and an honorarium from SpeechTherapyPD.com for her participation in this podcast. She has no relevant non-financial relationships to disclose. Renee Garrett is a paid employee of a private consulting firm in the Commonwealth of Virginia, and I'm the host of Brainstorms, Functional Neuro Rehab for SLPs, and other webinars on SpeechTherapyPD.com, both of which receive financial reimbursement from SpeechTherapyPD.com. My non-financial disclosure is that I'm the secretary for the Communication Disorders Foundation of Virginia. Now, without further ado, we welcome our guest, Dr. Rene Utianski, PhD, CCC-SLP, BC-ANCDS, she, her. She is a consultant in the Department of Neurology at Mayo Clinic in Minnesota. She's an associate professor of speech pathology and neurology. She earned her BA in psychology and speech and hearing science from the George Washington University. She earned her MS in communication sciences and disorders and PhD in speech and hearing science from Arizona State University. She completed a research postdoctoral fellowship at Mayo Clinic, Arizona, and a clinical postdoctoral fellowship at Mayo Clinic, Rochester. In her present role, her clinical responsibilities include differential diagnosis of acquired and degenerative speech and language disorders. Her research focuses on defining the distinguishing clinical, acoustic, and neuroimaging characteristics of these neurological disorders, refining their differential diagnoses, and informing subsequent treatment. So good to see you, Renee. Thank you for being here with us today.
You too. Thanks for having me.
Of course. So this is a topic that I think a lot of people have a lot of questions about. I know when I first started my career, it was not known as functional speech disorders. So do you want to talk a little bit about what we used to call this to kind of get started?
Yeah, I'd love to. So many people might know this group of patients as having psychogenic voice or speech disorders or having conversion disorder affecting speech, language, or voice. And we've really moved away from that terminology.
Yeah, and I remember when I first started my career, we called it conversion disorder, and we were taught to treat this as if it were an actual disorder, but to know that it's really not. In all actuality, it really is a thing.
Yeah, now we know that it is. Yeah, one of the other splits that's often discussed is, organic versus non-organic, which even that has become a little bit dicey. because we've really learned that there's a biological basis for these functional disorders. And so that suggests that there is an organic origin, so to speak. And so the terminology is constantly evolving and really being critiqued, and I think for the better.
Oh, I do too. Thinking about the past, like our past patients, when I first started my career, I was in inpatient rehab. And so some of the patients that would come over definitely had some psychological things going on. They had been worked up for pseudo seizures. They had been worked up for stroke. A lot of them had trauma that sort of accompanied this now presenting disorder that they were experiencing. And so I think, again, looking back at what I did early on in my career, now I'm kind of like, oh, ew, I can't believe
Oh,
I can't believe I
isn't,
believe the hype. But,
isn't that the case for all of us?
well, that's the purpose of research, right? To help us, expand our evidence-based practice and make sure that we're practicing the way that we should be in at the top of our game and utilizing that research. Yeah, and I'm just trying to think back now of, like I said, the ties to trauma, because I think that's a big one. Are there statistics that are more relevant, males versus females, or anything along those lines?
I'd be hard pressed to say that in particular, but what I do think is important is that the data definitely show that stress and trauma and anxiety and all those things might be risk factors for developing these, but we don't consider them causative any longer. And I think there's a really important distinction there, because there are a number of patients who don't have any identifiable stress, trauma, or thing that really precipitated the onset of it. And so if you think about trying to explain this to a patient and to say, yeah, stress causes this, and they would come back to you and say, I don't feel stressed. And then you're kind of at a loss, right? You're at a stop at the start of where you go and kind of treating and managing this problem. And so I think it's important to not prescribe any causative factor, even though it can be important to recognize those things when they do happen, because we really want to bring in the related mental health professionals and counselors to help people process those associated things to help prevent other functional disorders from happening or evolving.
So, do you want to jump into diagnosis, or do you want to jump into symptoms? Because I think they're both super interesting.
Yeah, maybe starting with the symptoms is a little bit more helpful to kind of lay the groundwork of, functional disorders are very real problems. They're a part of a larger umbrella of functional neurological disorders. And so there are lots of different types of things that can happen in a functional way. And so that means that there's not a disease directly affecting, say, the motor network or otherwise that's causing this problem, but that there is something happening in the brain that's causing these symptoms. So that can be things like weakness and paralysis, jerks and tics, gait disorders. Speech is what we're talking about tonight, but it can also happen in other areas of our scope of practice, like swallowing and language and cognition. And some of the more like popular media places that people may have seen this, if they haven't encountered it in their clinical practice, are, the Netflix show Never Have I Ever, Mindy Kaling. In I think the first or second episode, Davy has an arm that's paralyzed. And it does happen to be after a traumatic event. I won't give away any spoilers, but that is a functional paralysis. And there are lots of young girls on TikTok that are diagnosed with Tourette's, but I have strong reason to believe that they actually have functional tic disorders, referred to actually as the TikTok tics. And so the symptoms can be like anything you can see from a structural neurological cause. They're just happening from a non-structural cause. And so it really can be anything. And these problems can be constant. They can kind of wax and wane. They can happen in spells. And so for speech, any one of the subsystems can be impacted. I'd say by far the most common is a stutter, but it can happen with articulation and with prosody and accent and voice. And so any number of these things can be impacted and happen in combination too. And so it can be really tricky to tell them apart from the neurologic counterparts to those presentations. But I think there are a number of symptoms that can kind of clue us in as to what's happening. The question I most often get asked is like, well, how do you diagnose this? What do you have to do to know that something is functional? Because I think one of the major shifts that's happened in the last 10 years is that it's no longer a diagnosis of exclusion. We used to think of, well, it's not a clearly recognizable dysarthria or motor speech disorder, so it's got to be functional. But now we look for what we call these positive clinical signs to support that diagnosis. And I think that that's a move in the right direction because it really garners a lot more confidence from the patients. If you say, oh, well, this just isn't this, they're going to be left wondering, well, maybe I'm the first person to ever have it. Right?
Mm-hmm.
Versus if you say, these are the things that you have that let me know this is functional, they're going to say, oh, okay, that makes sense. And so, we're really looking for consistency of the problem. Sometimes if it's an articulation problem, someone will say, oh, I have trouble with my R's and then I have trouble with my S's. Or they'll maybe say, I stutter some days, but other days my voice just won't turn on. And so we know that the way that the motor system works, that really isn't a compatible problem with a structural neurologic damage. A couple of other things we look for really have to do with attention, which the neuroimaging research is really pointing to as a major part of these difficulties. So a lot of the patients will describe that, when I'm really relaxed or doing something I love, my speech is totally fine. Mm-hmm. And so, it's distractible, right? Their brain is not really paying attention to how they're speaking. It's focused on kind of what they're saying or what they're doing. And then on the other side, it's suggestible. So when they're talking about the speech problem is worse. Or during the structured exam of, I'm going to pay really close attention to how your speech sounds right now, or this might be a little tricky, but try your best. It tends to enhance the problem. And so those are the things that we really want to be looking for. I'd say those are the kind of top three, but there's also the patient's hypervigilance and attention to the problem. You may not even hear it and they'll say, did you catch that? That was it. Mm-hmm. And so it really is amplified in their experience, even if it's hardly perceptible to us at all. Yeah.
Well, and the one patient that I had talked to you about, she was, and it was very helpful to me. She was very good about keeping a journal of these incidents and things that happened. She was also undergoing psychotherapy at the time. So her therapist had instructed her to keep track of dates and times, how she was feeling, whether she was hungry, whether she was tired, just any symptom at all that she thought was relevant. But what wound up happening was her mom was a nurse. And so her mom was really good about videotaping the incidents because we never recreated it in the therapy room. But what would happen is she would come in with these videos of things that happened and she could define how she felt that day, any precipitating factors, anything that made it less, anything that made it worse, the duration of how long the episode lasted. And she sort of had this whole, the original reason that she got referred to me was dysphonia because she had a pretty significant what she called a vocal tic. She called it a bark. And so she would be sometimes dysphonic after it because of the stress that it placed on her vocal tract to be able to produce that successive sound at that pitch for so long. So it was really interesting to view it on the other side of how I had been trained and taught and to see, because this was someone who was fairly young, just 21, 22, something like that. And it affected pretty much everything, social, definitely psychological, her interpersonal relationships with family, work. She also had a concussion history. So there was a lot of layers. And I think that's a really important piece to kind of delve into too, because while you can have those diagnostic criterion, it's sort of like the what came first, the chicken or the egg mentality of is there, like you mentioned earlier, is there something that actually happened that was causative?
Yeah, it's a great point. And, I think the last statistic I saw was something like 10 to 15% of patients with a functional disorder have a comorbid neurologic diagnosis. And another recent paper came out showing that patients with multiple sclerosis tend to seem to be maybe perhaps more vulnerable to this. And I think there's something to that based on where the lesions tend to be in multiple sclerosis.
Mhm.
It's certainly Dr. Duffy, who I worked with at Mayo, Joe was common for saying, it can be ticks and fleas, right? It can be two problems at once. And I think what we have to do is focus on what are those positive clinical features to say, I really want to focus on this piece that I think is functional. And then we're going to see what we're left with, right? Because a lot of times, and we'll get to this, I think, a little bit later, patients are fairly responsive and fairly quickly to kind of resetting their system and overcoming these types of functional problems. And one of the analogies we often use for this, and I should have maybe said this earlier, was we use the analogy of a computer, right? That the computer has hardware and software, and the body has the same. It has the muscles and nerves as its hardware, but it has all these other things as its software. And for these patients, a lot of them will come to say, the tests are unrevealing, there's nothing coming up, there's nothing showing the problem. But most of those tests are looking at the hardware. And what our tests, what our listening, careful listening and pattern evaluation can do is look more closely at the software to see if that hardware is intact, but the software is glitching. And so most patients can get this analogy with, understanding a computer or a smartphone to say, sometimes you're not really sure what's happening, but if you restart the phone, computer, the tablet, it's able to work just fine again because the hardware is nice and healthy. And so for them, we try to just kind of reboot the system.
So I know you mentioned criterion for kind of what the symptoms look like, but what are some diagnostic tools that maybe we should be looking at and be using besides traditional, because a lot of times our patients come in and, like I said, the one I had most recently had a diagnosis of dysphonia. And so of course I'm thinking voice handicap index is a patient reported outcome measure. And did she go to the ENT to, examine, did she really have something structural or physiological going on with her voice? And and none of those things really were helpful, right?
Yeah. Right. Yeah. And so I do approach it with a standard motor speech exam. I get a case history. I try to look, was this a really abrupt in onset? And was it abrupt to a severe problem? Because that's highly unusual for neurologic disease, right? Even if it's onset later in life, it tends to start mild and get worse over time. So, kind of asking those key questions. How did it start? How's it been going? Has the quality of the problem changed over time? Have them do kind of reading, repetition, vowel, AMRs, SMRs, And then I think the two important pieces are, having a conversation with them. And I think particularly for younger clinicians, this is often a part that you kind of forget to do because you're so focused on the mechanics of like getting all this information and trying to make sense of it. But it's when you can see a really big change in the quality of their speech. So not forgetting that as a part of the workup. And then also doing the oral mech exam, looking at structure and function. Because if someone has a fluency presentation, you really expect the oral mech exam to be unremarkable. The structures should be normal, they should be strong, they should be fast. But in many cases, you'll see giveaway weakness, right? You try to push at the jaw, try to close it, and you can. Which even for patients with like severe spastic flaccid dysarthria, they can withstand most of that, right? And so that tells you that there's some incompatibility between the findings and the speech pattern that might raise concerns for a functional problem. And so I really think you can get all the information that you need from a standard motor speech exam. That said, I think that sometimes the workup can be a part of the treatment. What I mean by that is that, a lot of the patients will they have a lot of concern, a lot of doubt, understandably, a lot of questions. And it can be really helpful to reassure them that, yes, we know your hardware is working. We have seen it, right? And so I think that a thorough workup can be reasonable, but for some patients, it really isn't necessary, because if you can do the speech exam, confidently make the diagnosis, explain it, and then work through treatment, you can save them lots of time and lots of money and lots of aggravation. Yep, exactly. And so I think if we are positioned to do that, we can and we should. It's our right to.
Yeah, and I'm kind of backtracking in my mind about, I asked about statistics for male, female, but also age. Are we seeing more in any one particular age group? And I know a lot of people get tired of me talking about the pandemic, but there were a lot of things that happened during the pandemic that changed sort of my caseload demographic from diagnosis to age. Like I started seeing a lot more patients with diagnosis that didn't seem to fit a criterion for age, if that makes sense. Because usually, our stroke patients or Parkinson's patients are like, middle-aged to geriatric for the most part. There's always exceptions. But for a lot of the things that I started seeing in my outpatient practice was that there were a lot younger clientele coming in for a lot of things that didn't make sense, which sort of fits the bill for what we're talking about.
Yeah, the general statistic is middle-aged. Well, I shouldn't say that. I would be calling myself middle-aged, but 35 to 50 is the general early midlife, I suppose. 35 to 50 is probably the most common onset of these disorders, but I've seen kids as young as 9. I've seen adults as old as 87. And so really don't think that this problem discriminates. During the pandemic, we did see an uptick of teenage girls with these TikTok tics in particular. And I just saw an article the other day of where did the TikTok tics go? Because there was an influx of these patients during the pandemic into movement disorders clinics, and it really has seemed to level out. So, what that says about being on the quote unquote other side of the pandemic, I'm not sure, but it was certainly a unique time in our lives. I'll jump in with something if you don't mind, just in by way of statistics. I think that one of the common things I find myself talking about with patients is, am I the only one with this? How common is this? And the short answer for the most part is like, you're not even the first person I've seen with this today. Much more compassionate about it. But, the current statistics, again, are like 4 to 5 per 100,000. So that's about as common as multiple sclerosis. And I'd say 9 out of 10, not 10 out of 10 patients have heard of MS, but they've never heard of functional disorders. And so it can be really powerful for them to hear that it's actually fairly common and that they're not alone. But this really is not a problem that discriminates. I've seen well-adjusted CEOs, lawyers, doctors, to farmers and, across the education span, across the socioeconomic span, across cultures, it really seems to be fairly universal.
And I think one of the things that maybe is missing again for some SLPs is that I'm not really picking on outpatient, but because outpatient was where I saw this the most, I definitely saw it in inpatient rehab, but it was, again, we were told conversion disorder, just get them off your caseload as quickly as you can. But now I'm looking at it differently. And so thinking about some of the cases that I had who patients came in and they had this myriad of symptoms that was just, I don't want to say weird because that's not very kind, but they were just atypical symptoms, but they had like this symptom for swallowing and this one for voice. And then we know everything, wired here and neurologically and physiologically are wired together. And so we see one system affected that impacts something else. But there were a lot of times I had patients who came in and they thought it was just reflux, but they were having these issues with chronic cough and they were having issues with their voice. And they, again, maybe they were on a lot of reflux meds, but they weren't responsive unless they were. And I think that kind of goes back to what you said about like if they weren't being made aware of the problem, sometimes the problem was diminished. But in the case of things like chronic cough and some dysphagia symptoms that were more like the globus that we see with our reflux patients and stuff like that, what would you say is kind of the correlation there?
Yeah, well, I guess two thoughts. I think one is that when it comes to these disorders, there's a difference between managing it and resolving it. And what I've seen patients come through my clinic, even when they've had the right diagnosis, but maybe aren't making progress in treatment, is that they're working without a full appreciation for the mechanism, right? It's okay the way I can make this easier for myself is by doing this, right? Or make this less bad, versus having an understanding that we can fully reboot the system. And so I think that it's exactly a shared mechanism, and that, patients with globus and chronic cough and laryngeal hypersensitivity, these are all under what I would consider the umbrella of functional disorders. There's not a structural cause, although sometimes there can be a structural component, but it's not the direct cause of the symptoms that are most troubling to them. It can be like a secondary cause, if that makes sense. And so we really try to help have the patients understand what functional disorders are and make sure that they agree with what the problem is. And then we can shift gears from managing it to resolving it.
That's a great segue into treating and managing because, I like for people to come away with practical resources of, what do we do with these patients? I know what I did, but was I doing the correct thing? I hope so.
Well, if the patient saw improvements, then I think you were. But in terms of resources, I'll just have to give a nod to this paper that I had the privilege and opportunity to work with some really great speech pathologists, vocologists from around the world to do this consensus paper on managing functional communication, swallowing, cough, and related disorders. That includes laryngeal hypersensitivity too, and worked on consensus recommendations for diagnosing and for managing or resolving these problems. And so it's an open access paper through JNNP, the Journal of Neurology, Neurosurgery, and Psychiatry. And there's a short paper and then a long paper. And so for people who are seeing these patients a lot and scratching their head, I would definitely encourage them to look at this as a resource. But I think that my general approach to this is that the treatment starts when I explain the diagnosis. And so really trying to offer validation sometimes is the starting point. These patients will say, people are telling me this is all in my head. People are telling me this isn't real. And just saying, this is very real. I don't think this is anything you're doing on purpose. I've seen this before, and I think that I can help. And sometimes that is enough to cue the tears, that people are just so relieved, right? But I heard someone say this, and I think you even alluded to a similar sentiment of like, just don't do anything weird. Be the compassionate listeners and communicators that we are, and explain a functional disorder the same way you'd explain dysarthria, right?
Mm-hmm.
It's a problem in the brain that is causing these difficulties with your speech. But in this case, we can kind of help rewire things a little bit. And so kind of taking from that conversation, I'll often just say to patients, have I explained this in a way that makes sense? And do you agree with me that this is what the problem is? And most of the time they'll say yes and yes. And sometimes it will say, no, I just don't buy it. We don't move from that conversation until all the questions have been answered to say, what information do you need to understand or to agree? And sometimes they'll say, I just think this is genetic and I'm just going to wait for those test results to come back because I really think that's the problem. And I am generally very appreciative that they have shared that. And I'll say, my diagnosis won't change regardless of what the genetics results are. But I think your ability to participate and benefit from therapy might. because the same brain where you're having those doubts is the same brain that's going to have to do the work to fix this, and they can't live together. And so get the results and process them, and then call me after that's done and we can continue the conversation. And so I really think patient understanding and acceptance are sometimes 80 to 90% of the therapy. And then from that, we kind of move on to more symptomatic therapy. A lot of it is borrowed from the relevant symptoms treatment base. So, a lot of the approaches for stuttering and for fluency are borrowed from the fluency literature. Things like easy onset and kind of smooth speech. And I really try to take a holistic approach to patients. And I think muscle tension and tension in general is kind of a shared feature of this. Patients will say, I'm working really hard. And so sometimes the therapy is work less hard. And I say that playfully, but in seriousness, I'll have to talk with them. I say, it's going to be easier said than done, but I want you to try and not think about how you're making the sounds. And so a lot of the discussion can be trying to figure out what's going to work for that patient. But I think that I tend to start with reducing muscle tension. So I'll, say, are you kind of sitting as comfortably as you can? Might have them do some shoulder shrugs or neck rolls, take some deep breath. And they tend to really benefit from that. Sometimes they'll say, oh, that felt good. And when they say that, their speech sounds good. It really is impressive sometimes. Just that can make all the difference. Yeah.
Are you taking advantage of our new amazing feature? The Certificate Tracker. The free CE Tracker allows you to keep track of all of your CEUs, whether they are earned with us at speechtherapypd.com or through another provider. Simply upload your certificate to your registered account and you're all set. So come join the fastest growing CE provider, speechtherapypd.com.
Yeah, one of the things that, and I mentioned this just because she's so forefront in my mind because I spent so much time sort of looking at the layers of what she was going through and all these things, because she had a lot of psychological components to it, but she also had a lot of social issues. And so that was one of the things, was working on the mindfulness piece. And she was very open to like breathing techniques and sort of focusing on not necessarily just triggers, but focusing on how she could almost like preemptively stave this off by being in the moment and that kind of thing. So it was very interesting.
Yeah, I love what you just said there. It reminded me of something that I'll talk a lot with patients about, kind of what their triggers are, and also about kind of how that in and of itself, thinking about it happening, is creating a distraction that's taking away from the resources to communicate. And so people talk about this a lot after they get a diagnosis of saying, I'm just so relieved to know what this is. Like that frees up so much of my brain power in and of itself, versus thinking about how to talk is, taking away from brain power, and thinking about when is this going to happen next is kind of almost perpetuating the problem to happen. And so it's kind of a fine line between, okay, you have the tools if it happens, and now I need you to best you possibly can try to not think about it. So this becomes very concrete for like the swallowing functional problems, which I know isn't the primary topic, but a lot of patients I'll see will say, well, my speech pathologist was having me really focus on how I'm eating to help avoid whatever swallowing difficulty they have. But when I see those patients, I kind of flip it exactly on its head, and I'll tell them what we tell 99% of patients to not do. Say, I want you to eat in front of the TV. I want you to try your best to let your system remember how it's supposed to do its job without you interfering. And interfering is their subconscious. It's not an active interference, but it's their brain kind of getting in the way of things.
Yeah, no, that makes a lot of sense. And again, and this was something I did differently, just kind of like reading through research and trying to brainstorm how I could be a better clinician, was I started doing the sensory profile impairment. I'm probably not saying the correct, I can't remember now the official title, but I did that as not just part of the assessment from an insurance and payment, because gosh, I'm so tired of talking about that. We have to have a standardized assessment, but at the same time, for me, I found that it was helpful because it looks at different domains of a sensory profile. It's typically used more so with, kids or young adults with autism, but there's a wide range of things that it covers. And I found it to be really helpful to help kind of quantify what the patient was saying and saying, okay, if you have this, do you also have this in this space? How do you feel about this? And it covered eating, it covered smell, it covered texture. And so you're kind of able to discern the things that are hypersensitive for the patient and then the things that they don't really have a sensory response to. And I found that to be helpful, mostly for them from a psychological standpoint, but it was also validating for me to be like, okay, I get what you're saying here, and this makes sense now.
Yeah. Oh, I think that there's something to that for sure. On the speech side of things, particularly with patients who have these pretty notable fluctuations, their speech is self-prescribed normal for hours, days, weeks in between episodes, to encourage them to pay attention to when things are working well, because they're often very focused on when things are not. And so if you can figure out similarly what's not giving you difficulty chewing, swallowing, what's not giving you difficulty with when you're speaking, to think about how the muscles kind of feel and how your speech sounds, that kind of gives them their anchor point for what they're working for and for what they want the muscles to be doing. And so I think that there's a lot of truth to that.
Yeah, and I think one of the things that happened is it sort of became, even when I was talking with other SLPs about this, it was like, well, this sounds sort of like, because a lot of people here on the East Coast call it woo-woo. It's like, this kind of sounds woo-woo, like you're delving into this like next realm of meditation or whatever. And I'm like, no,
Needs to be a place in the middle, just a single woo.
Yeah, just a single, like shared decision making, understanding where the patient's coming from, and trying to make sure that the education piece and the counseling piece that so many people tend to still shy away from, which for me has always been such a big part of what I do in my practice because, as a family member first. And so I never felt like, and people who listen know this, I never felt like I had the education when I wasn't an SLP that I needed to know about my dad's aphasia and what happened and how we could help, and things we needed to do from our communication partner strategies and stuff like that. I didn't feel like I had that. So I've always tried to make that a forefront of what I do for patients that I serve, because it is still, to me, so lacking, and the research is there. We have all this research that says this is what you should be doing in addition to your standardized tests.
Yeah, two thoughts. I think one is that, the reading of the grandfather passage and the timing of it, along with AMRs and SMRs, that is a standard, if not standardized assessment. And this is what I do all day, every day, is diagnostics for motor speech evaluations. And I've never been denied coverage for an evaluation with that information. And so I really feel like we need to be empowered to use like what our rich clinical history is to do what we need to do and not get distracted by wasting time doing other things that are not going to give us the information we need as succinctly, because that's wasted time for really trying to treat these disorders.
Absolutely. Absolutely.
I don't know if I'm going to get in trouble, but I think that there's a lot of truth to it.
I was trying to be smart for a hot second. You go ahead because you're way smarter.
No, that's not true. I was just thinking about the insurance realm and anticipating some other questions that I often get are, can we diagnose this? And the answer is absolutely. It is a communication disorder. And so just the same way we would diagnose dysarthria, we can diagnose a functional speech disorder. The distinction comes that we cannot diagnose a functional neurological disorder. just like we wouldn't diagnose ALS, but we can diagnose the corresponding dysarthria. And so I typically use the speech disorder NOS ICD-10 code for functional speech disorders, and have again not had any issues with that. I am lobbying ASHA to work with us to create functional speech, functional swallowing, and functional cognitive disorder codes, because reimbursement shouldn't really be tied to scope of practice, but I think for a lot of people it is, and understandably so. And so I think if that is one step that can help us feel empowered to do that, then we shouldn't have to be working to try to, get the runaround for referring providers and other things. And so if anyone's interested in joining that advocacy effort, please feel free to reach out to me.
Yeah, one of the things I think I had put functional communication disorder, and our insurance person kicked it back and told me to call it speech sound disorder, which for this particular patient I could, because she did come in with what was diagnosed as dysphonia. So it's sort of learning that it's not really nuanced, it's more of a pain piece, but it's learning, especially if you're tied to a hospital system, what your hospital system is billing across the board, which, again, speech sound disorder is not inconsistent or incorrect. It's just knowing what they know as their insurance experts of what we're going to not have issues with. And then I don't say that for payment, because for me, I don't really care about that so much. I mean, it does pay my bills, but the problem is that for me, I care more about the restriction of visits and the restriction of treatment that could be impacted by the way that I bill or the code that I utilize that maybe they aren't super happy about or whatever, because I don't want someone to get kicked out for me not doing something correctly when they know, what'll be reimbursed and what won't.
Yeah, that's tricky, because I wonder if speech sound disorder would get kicked back for us, because there are other requirements for that for developmental issues, but I'm not sure.
We do have a question. Could you share any thoughts or experience with non-native accents? I had a teenage female patient years ago, native to the U.S., but who spoke with an English accent. I wish I could recall more details, but ultimately we couldn't identify a cause. Negative neuro and psych workups. We did a little bit of work getting her to imitate an American accent, and she was capable at a very structured level. But ultimately, the patient and her mother didn't feel there was a negative impact on her daily life, so we didn't continue to treat. I recall finding very little information about it at the time. Our entire department was stumped. Excellent question.
Yeah, excellent question. Super glad you asked. I'll put a link in the chat, and the link that I'm putting in the chat is for a Perspectives article that just came out in February, identifying and treating functional or non-native foreign accent syndrome. And it is one of the papers I'm really proud of because I co-authored it with the patient. And so there's a lot of information about our experience there. And I've treated probably at least a half a dozen patients with functional foreign accent syndrome in the last 10 years or so. And they all have very similar themes to kind of what came out in this experience. And, I think that foreign accent syndrome as an entity is, I'm going to be careful with my wording here. I have not seen neurogenic foreign accent syndrome, but I've talked to a lot of people at length about it. And what I understand to be neurogenic foreign accent syndrome is really a type of apraxia of speech, where there is kind of a quality of accent to it, but it really happens in tandem with a neurogenic motor speech disorder, a known structural lesion, structural motor speech disorder with this accompanying accented quality. But patients who have functional non-native accents, it tends to happen very abruptly. It tends to change quality, both kind of day to day, within conversations of different kinds, and even over time. So this patient had, I might get the sequence wrong, but it was, a self-described Cajun accent, Canadian accent, Eastern European accent. There's no neural generator that would do that, right? And so the inconsistency or the change in the quality of the problem was one of the clues to the diagnosis of it. This patient over time developed some other functional symptoms gait, vision, somatic difficulties, and was able to agree with the diagnosis and identified some self-precipitating factors or things that were kind of maybe triggering to the event. And we did some of what you just described. I said, okay, I want you to imitate other accents, or I want you to imitate your old self. And he was able to make some pretty good progress there, but it wasn't always able to fill the gap. And so we tried to focus on the elements of speech that were the root of the accent changes. So really that's primarily articulation and prosody, and in some cases language. But this is an approach I use for a lot of different functional disorders, and it's over-exaggeration. So I'll hand them the grandfather passage and I'll say, I want you to read this to me like it is the most interesting thing you've ever read. You wish to know all about my grandfather. And it shifts their focus to their prosody, that the rest of their speech kind of has to go on autopilot. So the articulation tends to normalize, and fluency can normalize, and other aspects of it as well. And so there are a lot of different ways that you could approach it, but I'd say that this is maybe 5-10% of functional cases I see fit in this non-native accent category. I could talk a long time about this, but I'll stop there.
No, I'm fascinated because this case was a neurogenic. This guy had a TBI. He had a fall and had a pretty significant bleed. And this was, again, inpatient rehab, man, that was my jam. Those patients, I can remember them like it was yesterday. And it was almost 15 years ago that I started my career there. And it was just so interesting because he woke up one day after he'd had a second stroke and he was speaking in a British accent, and his wife thought it was like, his family was there and they all thought it was like the funniest thing. And they just went with it, which made him sort of like this comedian in the best way possible, not in a disrespectful way or not in a like poke fun at him way. His family was they were all very close. And so they just found it so humorous that he was doing this. This was a guy from the Midwest by way of wound up in Oregon and came to the East Coast to visit, doing a tour of Revolutionary War battle sites with his brother is like their birthday gift to each other or something. It was like the craziest story ever. Came out of a restaurant, tripped on a crack in the sidewalk because it was dark, and he tripped and fell, hit his head, and then wound up having a stroke after the fact. But he did. It was not when I initially saw him in IPR, it wasn't that initial piece. It was after he had the stroke, probably 4 weeks after the initial TBI. So it was very interesting. And yeah, I mean, I really didn't focus a lot on that because at that point we were really focused on his swallowing. But he got to the point where he was realizing that he was doing it and couldn't stop it. And he then began to think it was hilarious too. And so his family was just great because, being supportive, but also making it a humorous thing so that he didn't feel like something was wrong with him.
Yeah. Oh, tough case. I think the problem being a priority for the patient is definitely something that influences treatment outcomes. Isn't that true for like everything that we do? But it does feel that these patients are particularly vulnerable to poor progress if they are either not bothered by it or otherwise just not motivated to correct it. But those patient-reported outcome measures, regardless of origin, I think can be really helpful to kind of track that thing. Sometimes you'll say, keep this at home, check in with yourself. And if once it gets above this score or this percent change, then give me a call back and we'll work on things,
Yeah. No.
Yeah.
And, we could probably do a whole nother episode for the functional swallowing disorders, but is there another particular case study that you have that kind of sticks out? Because I know that you have quite a few things that have been published in the last couple of years.
Yeah, a couple, I guess. One, I was reminded of when something you said earlier that, this was a early 30s woman, otherwise healthy, happy mom, teacher, and she had terrible headaches, and all of a sudden she had developed a stutter. and couldn't get rid of it. It was disabling to her. And she came to me. I was kind of doing the workup, and it was fairly straightforward in terms of diagnostics to me that this was, in fact, a functional stutter based on those positive clinical signs I was seeing. And I explained it to her, had her do some work. And within 7 minutes, she was speaking normally again. And what was so impactful to me was that she said, I tried doing those things before and they didn't work. And, we had a discussion about what was missing was kind of understanding what the problem was. These patients do not have control of what it is that is happening to them. And through an understanding of that something's kind of gone haywire and they've lost control, it gives them the capacity to regain control. And a lot of the neuroimaging literature in this space talks about a sense of agency and how having a sense of agency is saying, I am the one who is doing that. And the parts of the brain where that it is housed is really where there's a mismatch in activity, hyper or hypoactivated. And so that, I think, was a really important lesson in the importance of understanding the diagnosis and how powerful it can be for the treatment.
Well, and I think it speaks to, too, a lot of times when we're dealing with medical diagnoses, there's nothing worse than being dismissed or being told that it's all in your head, right?
Yeah.
Especially I think as females, and I say that because my own personal experience being misdiagnosed or being told that something is all in your head when it comes to female health issues and feeling unheard, and then thinking that you've done something incorrectly or you've done something wrong or that you maybe really are crazy, because that's where the space that a lot of the patients come in and they're like, I think I'm crazy. I've heard that so many times. I think I'm crazy, or I'm sure my doctor doesn't believe me, but here I am. And that it's a tough space to start in. But I think, again, it takes us back to that counseling and education piece that as SLPs is so important for us to start with building rapport and acknowledging, and sometimes just sitting back. And we like to talk because we're communication professionals, but sitting back and actively listening to what your patient is saying.
Yeah. It's so true. Yeah, there have been a number of patients I have seen who have stopped working. They've gone on disability, retired early. I mean, the list goes on into how deeply impactful these problems can be in a negative way on people's lives. And then being able to work with them, sometimes for an hour, sometimes across a couple of days, in rare cases, a couple of weeks, but being able to then return their speech, their identity, it feels just unreal sometimes. And I feel so privileged to be able to work in this space with these patients and to have the training I did to be able to work with them, because it can change things for them so incredibly. There are often a lot of tears when working with these patients, mostly happy ones, which when the rest of my job is in degenerative disease without cures, it's just a really heartwarming space. But we have a outpatient functional rehabilitation program for patients with functional neurologic disorders broadly. And so they come for 5 days and they do occupational and physical therapy once in the morning, and then again do each of them in the afternoon. And we are getting more and more integrated into that program and just getting to see the progress that patients can make. And there's a subset of them that I really like to get them first thing on Monday morning. And they make really good progress with me, and then it sets them up for really good success for the rest of the week. That said, there are some where I'm like, I'm not sure I want to try until Wednesday when they've maybe cracked things a little. I think there really are some different phenotypes. These patients are complex, and for some of them, it's kind of a one and done. It's a blip. We're not really sure what happened. But for some of them, it can be functional symptom after functional symptom, and they really need to work on identifying what we refer to as those perpetuating factors. Understanding this disease is really, or I should say disorder, is housed in the biopsychosocial model. And so we really think about those precipitating factors, perpetuating factors, and predisposing factors. And so we really try to figure out what are the things that are going to make this person most vulnerable to it happening again, and try to then manage what we can within our scope, of course, but then refer out to help deal with the rest of what they can. So I think it's relevant here. But one of the things that I often do, particularly after someone's had a return of their typical speech, is that I'll have them imitate what the problem was and then get out of it. And so that they know that they have complete control of it, which can be really empowering to them. It's really scary exercise, but it can be really effective and beneficial.
Yeah, and I think that's probably a bigger question that a lot of people might have, is quantifying the time frame of what the treatment looks like and how long do you keep this patient. Is this something you're doing 2-3 times a week for 4 weeks, or following some sort of protocol? And I think I'll be quiet and let you answer that question.
Yeah, it's tricky. I think that as soon as I make the diagnosis, I try to do a trial of treatment as soon as possible, within that diagnostic session, because I think it gives the patient confidence in the diagnosis, and it lets me assess their therapeutic potential. And in some cases, it fixes the job, right? But I think that, I work at a tertiary care center, so my statistics are going to be a little bit skewed because patients don't have the privilege of staying and following up for weeks at a time. But I'd say that as long as patients are making progress, stay the course. If they're not making any amount of progress in even like 2 sessions, something needs to be reevaluated. I don't take for granted that a single therapy goal may be that patient understands the diagnosis. Patient can explain the diagnosis, and it may take that amount of time, but it's really, really worthwhile.
Yeah, especially if it is, like you said, requires a referral to something else. And it brings up a really super young patient that I had who was, gosh, I don't even know if she was 20, but she had a lot, not just communication, but swallowing problems. And she had been to a couple of other SLPs before, not locally, but in other places when she was treated for other disorders. She had a genetic syndrome, and it's lost on me. I can't remember, but what she and her mom described was that she spoke in a Minnie Mouse voice, is what they would say, but she was also very petite. Her anatomy was very petite. But what was happening was she had been diagnosed with an eating disorder, but it didn't seem like an eating disorder in the way that I had seen other patients who had eating disorders. This was more like she was fearful. There was a lot of psychological stuff surrounding it. She had lost weight. But one of the things that we talked about was looking at the feasibility of manual therapy for her voice, and just seeing if it was something that we could replicate anything that she felt when she was having all these issues. And she hated it immediately. She's the only patient I've had do it when I did manual therapy who was like so averse to it. I mean, like as soon as I touched her, she was like, stop. Which is, again, that's a shared decision making, and I'm fine with stopping. But it was just, I referred her back to neurology and really encouraged her mom to go to a larger neurological center like a Johns Hopkins or a Mayo or something like that, because there was something missing for this young lady. I mean, this had impacted everything for her. And it was really, I kind of felt helpless too, because I'm like, I suck at my job.
No. We all have those days. And I think this is a topic on which I am extremely passionate, and I am committed to really helping our community better understand and better help these patients, because I think as speech pathologists, we are uniquely poised to hear the people that other people aren't listening to. And particularly when it is a communication-based problem, to help better characterize those difficulties. I mean, I didn't mention it before, but of the patients with functional neurologic disorders, about 50% of them have speech problems. And so, it's not an uncommon thing that we're going to encounter, and it really is going to be across the lifespan and across the work setting. Seeing kids in schools, seeing patients in the hospital, seeing them in the outpatient. Would be very surprised if they're not in the nursing homes or in home health otherwise. And so I think it's something that we really need to do our diligence and talk to each other about what it is we're seeing and try to help each other help these patients. And yeah, happy to answer questions as people have them about this. I think you'll post other resources, but there is one other paper that I'll put in the chat that was in AJSLP that has more of kind of the step-by-step instructions of kind of how we do the parts of therapy, because an hour goes super quickly and we didn't get into all the nitty-gritty, but happy to answer questions people might have.
Yeah. No, and I had posted one of the management that was on the fndhope.org page. I posted that one earlier in the chat too. So, and we can add these to the show notes as well. But, I don't think our meeting was by accident. And so I'm so glad that you agreed to join for this podcast and to delve into this, because it is a really important topic and something that we're definitely, I feel like, seeing more of in various practice settings. So I appreciate you being willing to share your knowledge and expertise. And so we'll kind of, wrap up. And if you have any final thoughts or anything you want to leave us with.
Thanks for the opportunity to be here. I think the one thought is just not let the pendulum swing too far. Just because something is unusual doesn't mean it's functional, but just because it's unusual doesn't mean it's not. So really try to look for those positive features. And if you need a second set of ears, always just look for other people in the community to help talk through things. And I think we can do good support for each other.
I agree. Well, thank you again, Renee, for being here. Thank you, and look forward to seeing you again.
Have a good night, everyone.
If you have indicated that you are part of the ASHA registry and entered both your ASHA number and a complete address in your account profile prior to the course completion, we will submit earned CEUs to ASHA. Please allow 1 to 2 months from the completion date for your CEUs to be reflected on your ASHA transcript. Each episode comes with an accompanying audio course on speechtherapypd.com, available for a 0.1 ASHA CEU. And just for our listeners, get $20 off any subscription with promo code BRAINSTORMS20. SpeechTherapyPD.com is run by SLPs for SLPs. We've got the largest library of ASHA CEU eligible courses out there, adding fresh content every week. Remember, use Brainstorms20 to get $20 off access to over 1,000 courses for an entire year. Head over to SpeechTherapyPD.com for more information and start earning CEs today. Thanks for tuning in to Brainstorms, Functional Neuro Rehab for SLPs. And don't forget, SpeechTherapyPD.com is your go-to for all things ASHA CEUs. Your positive reviews and support mean the world to us. We'd love for you to drop us a quick review and hit that follow button.